What are the non-modifiable risk factors for cardiovascular disease? Cardiovascular disease can be caused by a variety of risk factors we cannot control. The older you are, the more prone you are to chronic conditions like heart disease or stroke. However, men have a higher risk of cardiovascular disease earlier in life, while women are more at risk after menopause. Women may also experience different symptoms of heart attack that may go unrecognized. You may be more at risk depending on your ethnicity. People of Asian, African, or First Nation descent have higher rates of cardiovascular disease. Your ethnicity may also influence your diet, which can put you at an increased risk for cardiovascular disease. If you have a first-degree relative who has had cardiovascular disease or a stroke before the age of 55 for men and 65 for women, your risk of heart disease doubles, and regular screenings with your doctor are recommended. But there is good news. Up to 80% of premature cardiovascular disease can be avoided and more effectively managed by taking these proactive steps. Quit smoking, be physically active, eat well, achieve a healthy weight, manage your stress and any anxiety or depression, and see your doctor about managing your cholesterol, blood pressure, and blood sugar levels. For more information on cardiovascular disease, please visit our website.
BEaTS Radio, scientists interviewing scientists. Canada is a worldwide leader in science and innovation. However, our communities need to be more connected to current scientific research in order to drive the future of scientific innovation. So what steps can we take to more actively engage and connect our community with scientists and vice versa? Innovation and discovery are at the core of the current efforts of our government, but science sometimes gets slightly complicated to understand. At BEaTS Radio, we will tackle this by having young scientists and early career researchers interviewing scientists and innovators. By dissecting science in simple terms, this will allow our community to better understand the importance of science for our country. Hello to all of our listeners, and thanks for tuning in to this week's episode of BEaTS Research Radio. My name is Hallie Arnott, and I am the Canadian Biomaterials Society Ottawa Student Chapter President and a graduate student in biomedical engineering at the University of Ottawa. Today, we're back here on BEaTS Research Radio to communicate scientific research that's being conducted in the labs, like the one we're in right now, to you in the community. So what we're trying to do here is to give everyone a better idea of how therapeutics and medical technologies make their way from the lab to the clinic. Before we get going today, I'd like to thank the University of Ottawa Heart Institute, eLife, the Canadian Biomaterials Society, Ottawa Student Chapter, and the Department of BMI at the University of Ottawa, who are supporting us here at BEaTS Research Radio. Also, don't forget to subscribe to our YouTube channel, and you can find our podcasts on Spotify, Apple Podcasts, and Google Podcasts. With us today is Dr. Robert Jankov. Dr. Jankov is a neonatologist at CHEO and the Ottawa Hospital and a senior scientist with the CHEO Research Institute. And he's also a professor in both the Department of Pediatrics and Cellular and Molecular Medicine, both part of the Faculty of Medicine at the University of Ottawa. Dr. Jankov received his medical degree from the University of Melbourne, Australia, and completed his residency training in pediatrics at the Royal Children's Hospital, also in Melbourne. After completing a clinical fellowship in neonatal and perinatal medicine at the University of Toronto, Dr. Jankov then completed a PhD at U of T. He also worked as a neonatologist and senior scientist at Sunnybrook and the Hospital for Sick Children in Toronto. Dr. Jankov's research is focused on obtaining a better understanding of chronic pulmonary vascular disease in neonates. His research interests are centered around vascular remodeling, right ventricular dysfunction, and nitric oxide unresponsiveness in pulmonary hypertension in early life. Today, Dr. Jankov is going to be speaking to us about what we can do for babies who are born without enough lung. So thank you very much for joining us today on our research podcast.
Thank you for having me, Hallie.
Could you tell us a little bit about your role at CHEO and also working at the University of Ottawa as a professor?
Yes, so I have a few roles. Of course, primarily my role is as a clinician scientist. So I run a lab at the CHEO Research Institute, where I'm a senior scientist. From an administrative point of view, I'm also vice chair of research in the Department of Pediatrics at CHEO. And that sort of allows me to have a lot of interaction with research training to support the endeavours of our faculty there in the Department of Pediatrics. I'm also cross-appointed to the Department of Cellular and Molecular Medicine, where obviously there's a lot of interactions in terms of graduate teaching and so on. So those are my main roles. Yeah.
Okay. So what brought you from Australia to Canada? So it was the clinical fellowship at Toronto, but was there anything in particular that drew you to working in Canada?
Yes, it's a long time ago now. That was back in 1996 when I moved from Melbourne to Toronto. In Australia, when one does subspecialty training, it was and probably still is the norm for one to go overseas and round off their training at the end. Traditionally for Australia, that's the UK. That has been the UK, but North America more and more, especially in the 90s when I went. My own feeling was Canada felt like a more familiar place for me.
Okay.
Plus, a colleague had just returned from Toronto and saying great things about it. So I decided to follow that person and set up temporarily at the time. That was the intention anyway. At the University of Toronto and primarily at Sick Kids, but also the fellowship took place at Mount Sinai Hospitals and Sunnybrook Health Sciences Centre as well.
Okay.
Yeah.
So now getting into more of your research. So what do we currently do for babies who aren't born with enough lung, and what is the most common type of this chronic pulmonary vascular disease that you see?
Mm-hmm. Yeah, it does come in a number of forms. All of the diseases of babies that affect the pulmonary vasculature are disorders of development. Okay. And there are some that are rare, and there are others that are more common. The most common form is that which arises from premature birth, especially very premature birth, and we're talking about babies who are born under 1 kilo and under 29 weeks gestation, term being 40 weeks.
40, right.
And in that population, the earlier babies are born, and these days we do have babies in the NICU as early as 22 weeks gestation, which is much earlier than it was when I started my training. Back then it was about 27 weeks gestation. And as we got better with our mechanical ventilation, with nutrition, with all kinds of ways of supporting these babies, that line of viability has increasingly has become lower and lower. So in the babies that are born at that very low gestational age, 23, 24 weeks, more than half will develop a chronic lung injury called bronchopulmonary dysplasia.
Okay.
Now, BPD is essentially an arrest of the normal development of the lung. What should happen in the last part of pregnancy and in the first 8 years of your life, approximately, is that your lung becomes much more complex. It forms what are called alveoli, which are these grape-like structures that vastly increase the surface area of the lung that's available for gas exchange. What occurs in these babies that are born early is that in many cases that development just stops and never regains momentum. So even though the lung grows with time, you're stuck essentially with a lung that has far less surface area,
right.
and as well less efficient gas exchange than a normal lung. At the extreme end, the babies who are most affected will not survive and will not either not be able to be resuscitated or will die in the NICU. But the vast majority nowadays do survive. About 70% of that population will survive to get home after a very long hospitalization.
And that percentage is so that would be 70% are now able to get home after the hospital. Was it like that in the 90s as well, or has it progressed in the right direction?
Essentially, that 70% figure applied to more mature babies back in the 90s. So, late 80s, early 90s, and that we were talking more about babies born at 27 weeks as opposed to now talking about 22, 23, 24 weeks. So we have progressed from that point of view. The problem is that we are also allowing all of the technologies we have are allowing a population of infants to survive who are set up for lung disease in the future.
Right.
Yeah.
So they would a baby who's born premature with this type of chronic pulmonary disease, would they experience issues later on in life or complications?
They do. The estimates are that the complications of prematurity, especially the pulmonary complications, in terms of cost to society in health costs and so on, is second only to asthma. Asthma is a very big disease in pediatrics. So there is increased need for hospitalization, medication, and so on. And there is a link between lung disease and brain disease as well. So that the worse your lung disease is, the worse your brain disease is. We don't understand that link very well yet, but we're doing some interesting work in collaboration with people at the University of Utah in the US to try and understand that link. But of course, that also leads to issues with schooling and needing extra help and so on.
And what do we know about that link right now between the respiratory and the neuro?
Not very much. Only that it's a very strong link. The worse one form of disease is, the worse the other is. I suspect that it probably originates in the lung, and with some work we're doing in animals, hopefully we'll uncover that link a little bit better. Because of course the brain injury is also of great concern as well. What we don't know about this population is what are they going to be. We know what many of these children are like in their 20s, as young adults, and we know that their lung injury has not recovered, although they tend to live relatively normal lives within certain constraints, that are of exercise and so on, that are created by their lung injury. What we don't know is what happens to them when they're 30, 40, 50, 60, especially if they smoke and so on. And what we know about the lung is that the lung function peaks in one's early 20s. And then thereafter there's this sort of inexorable decline in function of your lung. But most of us don't become symptomatic, until maybe we're in our 70s or 80s and so on. If you start with less lung, the chances of becoming symptomatic earlier on is much, much higher. It's just that this population of children are not old enough yet for us to know what they're going to be like. But I think there's a big concern that there's a tsunami of lung disease coming, like an early onset COPD type of lung disease. So that's the context in which most of just to summarize that point, that's the context in which most chronic lung injury is seen from the neonatal population. And we know that respirologists do understand now to ask about premature birth as a risk factor when they see adults. And that can present a number of ways, not just with asthma and other respiratory diseases, but also with pulmonary hypertension, which is the main presentation of chronic pulmonary vascular disease.
So a baby that's born prematurely and possibly with chronic pulmonary disease, would they how is it detected? How would a healthcare team know about this?
It's a very good question, and the our ability to detect it is very primitive at this point.
It is, okay.
We base it essentially on what kind of help the child needs, and the definition of BPD is one that's defined by its treatment, and that is oxygen. So if a baby that's born early, and then at 36, when they get to 36 weeks, corrected gestational age, if they still need oxygen or other forms of help with breathing, such as CPAP or mechanical ventilation, they are defined to have BPD, and the severity is proportional to the amount of help that they need. So when you think about it, that's probably one of the few diseases that's actually defined by its treatment, which is somewhat problematic.
So this this type of disease is only able to be detected once the baby is born, or is there any way to?
No, we know that there are risk factors that will increase the chance of a baby developing BPD.
Okay.
Over and above prematurity, of course. The more premature you are, the more likely you are to develop BPD. But for example, if the fetus is not very well grown, if they're smaller in weight than they should be for that gestational age, their risks go up a lot.
Yes, okay.
As well, if there's infection during the pregnancy, a condition we call chorioamnionitis, which is a bit of a mouthful, but essentially it means infection of the placenta and membranes, fetal membranes, and that does increase the risk quite substantially of BPD. So we know that there are some babies that are set up for it, and we can tell usually within the first week or two of their NICU course, based on X-ray changes and their need for ventilatory support. We can tell with pretty good precision which baby is going to have this issue. The problem is what to do about it.
So on that same topic, what are we currently doing now for babies who are born with this type of disease?
The most common treatment at the moment is corticosteroids, which is kind of something we use for things that we don't understand quite often.
Yes.
And it's very effective at reducing lung inflammation. We have to be very judicious with it. The reason being that the earlier you give it in life, the more likely corticosteroids are to be linked with adverse neurodevelopmental outcomes. So it can affect the brain as well. We don't really understand its effects on the lung in the long term, but in the short term, it's very effective at reducing a baby's need for support. So it's a way we use of getting the baby off a ventilator if they're stuck, as we say, that we just can't get them off. Corticosteroids are very good at getting the baby off the ventilator. But I think there's very little evidence to suggest that it has any long-term impact on the trajectory of the lung growth. From there on, it doesn't improve that. It really has short-term effects. Yeah.
So how are these steroids administered? Are they intravenously or?
It depends. If the infant is taking enteral feeds at that point, it can be given orally. The one we usually use is dexamethasone, which is a very potent synthetic corticosteroid. It can be given both IV or oral. It really the route really depends on whether the baby's feeding or not.
How long would a baby stay on this type of steroid and medication? Would they depend, or do you see maybe a decline in their in how their lungs are working after you remove them from this type of steroid?
The answer is as short as possible. So we usually stick to a 7 to 10 day course, not a long course, just enough to have the effect you want. You do see rebound worsening of lung disease or lung function after the steroids are stopped, and sometimes they need more than one course. But really, unfortunately, despite many years of looking at this, our approach to BPD hasn't changed much in the last 20 years.
What do you foresee being maybe something that will begin as a breakthrough for this field of study?
Well, what we really need to do is encourage lung growth. We know that the way the lung develops is that it's a BPD and other disorders of lung growth are vascular diseases because it's the vasculature that drives the growth of the airways. It is crosstalk, but if you specifically diminish vascular growth, you will also diminish airway growth as well. So we need to find ways to stimulate vascular growth. Now, we can certainly talk a bit more about some specific approaches, but there's certainly a lot of pathways that are of interest to me. One of which is the nitric oxide pathway.
Yes, that was my next question for you.
Yeah.
So I think a recent paper that you just released was about how nitric oxide can help these babies.
Yeah.
Or
It was essentially an animal
nitrate.
study, and it was the first of what I hope will be a series of studies looking at an alternative form of nitric oxide therapy. So nitric oxide is essentially a small gaseous molecule that dilates blood vessels, and in fact, it's been an excellent. It's used as a therapeutic gas in ICUs, and in fact, the NICU was the first place for it to be used way back in 1992. Just when I was a young lad thinking about what I wanted to do with my life, and it was really treatments like that came along that made neonatology very exciting for me. And that was an excellent treatment for a disease in newborns where the normally high pulmonary vascular resistance in the fetus persists after birth, and it leads to hypoxemic respiratory failure. And that was a very difficult thing to treat until inhaled nitric oxide came along. Then it was realized that nitric oxide is actually a driver of vascular growth as well.
That's good.
And many of us thought, hey, inhaled nitric oxide could work for that. And many trials through the aughts, the 2000s, I think it was in the 2000s, mostly late 90s, examined effects of inhaled nitric oxide and preventing BPD with very disappointing results. And my work over the years in looking at effects of inhaled nitric oxide in animals suggests that there is a good effect, but there's also a downside to inhaled nitric oxide, and that is because nitric oxide is also an oxidant and a nitrating agent. And because the lung is directly exposed to it, our data shows that both in the lung and in the right heart, you do see increased oxidative and nitrative stress as a result of inhaled nitric oxide, which brings me to sodium nitrite, which was the treatment that we used in that study. And that has a number of advantages, and one of which is that it doesn't tend to be cause as much oxidative and nitrative stress. And it acts as a nitric oxide donor within the body. It's also very cheap because inhaled nitric oxide is extremely expensive, thousands of dollars a day. So in that particular study, which was a first study, what we looked at was the reversing effects on established pulmonary vascular disease in a chronic hypoxic model in animals. And what we found was that treatment reversed the pulmonary vascular changes. So that's a very exciting finding, and it would benefit some of our patients. But if we're going to see whether nitric oxide helps to fix the lung, what we need to do is look in more BPD type models. And one of my interests over the years has been to develop better models, predominantly in rats, to replicate what we see in babies. And so what we're doing now is looking at both the effects of systemic and inhaled sodium nitrite on lung growth and injury in several BPD like lung injury models. It's a bit early for me to tell you what we're finding. The data is coming off the press, so to speak, right now. But I'm hopeful that may well be an answer.
Just from listening to you, it sounds like a promising pathway.
For sure,
a lot of years of
some people have called it nitric oxide on steroids. So I'm hoping it's the good side of steroids, not the bad.
Me too.
Yeah.
So we will take a short break now, and we'll be back with the rest of this segment in just a few minutes.
Thank you.
What are the non-modifiable risk factors for cardiovascular disease? Cardiovascular disease can be caused by a variety of risk factors we cannot control. The older you are, the more prone you are to chronic conditions like heart disease or stroke. However, men have a higher risk of cardiovascular disease earlier in life, while women are more at risk after menopause. Women may also experience different symptoms of heart attack that may go unrecognized. You may be more at risk depending on your ethnicity. People of Asian, African, or First Nation descent have higher rates of cardiovascular disease. Your ethnicity may also influence your diet, which can put you at an increased risk for cardiovascular disease. If you have a first-degree relative who has had cardiovascular disease or a stroke before the age of 55 for men and 65 for women, your risk of heart disease doubles, and regular screenings with your doctor are recommended. But there is good news. Up to 80% of premature cardiovascular disease can be avoided and more effectively managed by taking these proactive steps. Quit smoking, be physically active, eat well, achieve a healthy weight, manage your stress and any anxiety or depression, and see your doctor about managing your cholesterol, blood pressure, and blood sugar levels. For more information on cardiovascular disease, please visit our website.
BEaTS Radio, scientists interviewing scientists. Canada is a worldwide leader in science and innovation. However, our communities need to be more connected to current scientific research in order to drive the future of scientific innovation. So what steps can we take to more actively engage and connect our community with scientists and vice versa? Innovation and discovery are at the core of the current efforts of our government, but science sometimes gets slightly complicated to understand. At BEaTS Radio, we will tackle this by having young scientists and early career researchers interviewing scientists and innovators. By dissecting science in simple terms, this will allow our community to better understand the importance of science for our country. Hello and welcome back to BEaTS Research Radio with our second segment with Dr. Jankov. If you missed our first segment, Dr. Jankov is a neonatologist at CHEO and the Ottawa Hospital and a senior scientist with the CHEO Research Institute and a professor with both the Department of Pediatrics and Cellular and Molecular Medicine with the Faculty of Medicine at the University of Ottawa. And today, Dr. Jankov is talking to us about his research that involves saving babies who aren't born without enough lungs. So to get back into what we were speaking about before, we were speaking a little bit about how complex the lungs are and a couple of different research avenues that are being taken. But do you think that it is the complex geometry, the truncate geometry that is involved with the lungs that's so that makes it so difficult to study this organ?
I think so. The lung is a uniquely unusual. It's an unusual organ, both from its structure and its function. From the functional point of view, if you think about the circulation of the lung, it's the only organ that takes the whole cardiac output, and that makes it unusual. It also responds differently to hypoxia than does the systemic circulation. It constricts as opposed to dilation in the systemic circulation. So there's already some fundamental physiological differences between the lung and other organs. But from the structural point of view, its role is gas exchange. Its main role is gas exchange. which means that there's a vast network of capillaries that are in close apposition to airways where oxygen and CO2 only have to go a couple of microns to go from one compartment to the other. Think about how complex that would be to replicate.
To replicate, yeah.
So certainly in vitro cell culture systems are not nearly complex enough, even when you have multi-cell types and so on, because the lung has a large number of cell types as well that interact in ways that we are only just beginning to understand. From the point of view of the structure, I think I alluded to the fact that alveoli in the lung are like many bunches of grapes that are present, moving in all different directions around the lung. If you imagine around each grape is a meshwork of capillaries.
Okay.
So the ability to replicate that in an ex vivo system is really has never been achieved.
Right.
Which is why we rely so heavily on animal models to develop our understanding of markers and molecules that may have a pathogenic role. There is work going on currently looking at lung scaffolds. So if one takes a lung and decellularizes it, and then you're just left with the extracellular matrix, the elastin and collagen and so on, and then use seed different cell types on it, stem cells and so on, and see what happens. The problem there is that you again are not replicating the way the lung develops, and that is that vessels come first, and airways come along with them. You're kind of throwing in everything at the same time and hoping that they'll sort of find their way. I'm not saying it's not a good way to go, but I still think in general that in vivo models are still the only way that's going to bring us forward. With all of the problems that they have too, of course.
Okay, the decellularized matrix, it's missing the vasculature that it needs, and
that's right.
I guess once the cells are seeded, that will become part of the scaffold later on, or it's never going to be?
But that I don't know. I mean, I don't think it's gotten sophisticated enough yet for us to be able to say with any certainty. What we can say is that epithelial cells, which are the cell type that lines the alveoli, are able to seed and grow and so on. What happens to the vasculature? I've not read anything yet that tells me that you're able to actually rebuild a lung from the scaffold up.
Okay. So the studies that you're doing now with the sodium nitrate, are those animal models or the decellularized?
No, these are animal models. I haven't worked myself with the decellularized lung. My own feeling is that as difficult and costly as it is to do in vivo experiments, it's still the best way and the closest way to get to translation, get from the lab to translation. So of course, yes. So I did mention the sodium nitrite experiments that we're working on, and there are a number of other pathways that we're looking at as well, including a molecule known as rho kinase inhibiting its activity, and these are very promising avenues. There are issues to be overcome. For example, rho kinase inhibitors are very potent vasodilators and can't be given systemically. It's a very good way to make someone ill. So they have to be delivered directly to the lung, and because of their very short half-life, of these drugs, we need to find ways to be able to give the medication less often and have it work longer, and a very fruitful collaboration that's ongoing currently with Dr. Alakon's lab, looking at liposomal encapsulation of one of the rho kinase inhibitors, Fastil. I think is going to be very exciting as we move forward, and could also be a fairly short path to clinical translation as well, I hope. Nothing's ever quick in clinical translation.
No, definitely not. That's a very interesting project. Could you elaborate a little bit more on that, and I guess what's been done there in terms of, is this a drug that you're giving locally? Would it be given orally, or?
No, it would be given by inhalation. So we have a a very sophisticated system for delivery of drugs directly to the lung using nebulization.
Okay.
It's a computer-controlled system that that allows one to deliver in a very precise way a quantity of drug that you want to deliver. And of course, while we're figuring out how often and how much, it's very good to have the control over how to deliver the drug, so that we can understand not only how much you need to have a positive effect, but also are there any downsides as well, which is why I think an in vivo model is very useful, because you can actually look at the long-term effects as well. And to that point, one of the BPD models that we've generated just recently, which is an advance over previous models, is that its phenotype persists right throughout its life, just like it does in babies with BPD who grow into adults with chronic lung disease.
Right.
All of the models, or the majority of the models before, were very short term and didn't have an adult phenotype. But I'm very excited by our ability to sort of use this particular model, which we call the hyperoxia intermittent hypoxia model. Don't worry about the details too much, but essentially what that does is it creates a progressive lung disease. So the lung disease is actually worse in adult life than it is even at the end of the injury period, which in the rat is during the first 3 weeks of their life. Okay.
And this Rho kinase, what would be the most ideal outcome of this project? What are we looking for here?
Well, what we are doing is we're giving the Rho kinase inhibitor both in two ways. One as a preventative drug, that is at the onset of injury, to see does it prevent the injury, does it stop the arrest of lung development that occurs with the injury. That's the first question. So one could see that having a clinical application.
Yes, definitely.
In that, since we can predict with fairly reasonable certainty which babies are likely to develop chronic lung disease with about 60% certainty, of course that means you're going to have 40% of infants who don't need the treatment.
Right.
So that's something to be thought about, and speaks to the need for better biomarkers and so on to predict which babies are going to develop BPD. But the other approach we're also taking is the rescue approach. So that is a baby or an animal who has established lung disease, and can we not only prevent it from getting worse, but also stimulate lung growth where it had been arrested before. So those are the two approaches we're taking. We're starting with the preventative approach as a proof of principle, and over the next few years we'll move to the rescue approach. But again, the model does lend itself very well to looking at both approaches,
cases,
and the rescue approach definitely has a lot going for it from a clinical applicability point of view, for sure. Yeah.
So, on the topic of clinical applicability, what's it like working both as a neonatologist in the clinic, but then also working very heavily on the research side?
I think it's uniquely rewarding. It's certainly hard work. I won't lie about that.
Yes.
Certainly when it comes time to write grants and review grants and so on, it's a very very busy time. I can say, I'm certainly a member of a small fraternity. Certainly among neonatologists in Canada, there are something like 300 neonatologists in Canada, but there's only less than 10 who actually are scientists as well. So we're a fairly small number. So I feel privileged to be part of that very specific community, and I think being a clinician scientist is, essentially we straddle being able to straddle both worlds. We're able to generate our questions from our clinical work and try to apply that into our research, and also try and it's definitely harder to bring things back the other way, but certainly it's. I'm also interested in supporting new clinician scientists or new developing clinician scientists. Unfortunately, with funding rates and so on being what they are, probably that's part of it. There's been a lot less interest from trainees in taking that path of becoming clinician scientist, doing the training, but also getting your lab established and up and running. I'm very engaged in supporting people who are not only encouraging them to take that path, but also supporting them once they've made the decision. And there is not only locally here in Ottawa and in Toronto, where I was previously, but also there is a Canadian-wide organisation in child health that supports clinician scientist training that I have been very, very heavily involved in. So it's hard, but it's rewarding. I certainly wouldn't trade it for anything else, and it's the main reason why I'm still in Canada. You asked me earlier why I came from Australia to Canada. You didn't ask me why I didn't go back. And essentially, the plan was always to go back, but I realized with time that I wanted a career that involved research, and really the system in Canada is set up, to support clinicians who wish to undertake most of their time in research as opposed to clinical work, much more so than in Australia. So even though it was a long time to make that decision, it got made, and here I still am 23 years later.
So that network that you were speaking of, the neonatologists who are also, so they're the clinician scientists. Do you find that network, you bounce ideas or work together oftentimes, or is it hard to do that when it's across the country maybe?
Oh no, Canada is a big and a small place at the same time, and certainly I see my fellow neonatologist clinician scientists quite regularly at conferences, at grant panels, and so on. And even though there are a couple of us who are working primarily in the lung, both of us are here in Ottawa, actually. Dr. Bernard Thébault is the other clinician scientist here in Ottawa, who's a neonatologist as well. But even though we do different things, we have a lot of interaction in areas that overlap, but also in general, helping each other with grants. Staying on track and moving forward.
Definitely.
Yeah.
So working on the clinical side, do you see any breakthroughs that have recently happened, and then also on the research side, do you see any breakthroughs that you think might translate into the NICU in coming years?
I'd say in the NICU, most of them, I'm hoping there's a big breakthrough coming soon. There hasn't been one in a while. It's been a lot of small incremental improvements. That's why in 1996 the edge of viability was 26 or 27 weeks, and it's now 22, 23 weeks. And these are small changes. The big changes when I was a resident and encouraged me to go into neonatology. The first was in 1990 was the introduction of exogenous surfactant, which treated what was then the most likely cause of fatal disease called respiratory distress syndrome as a result of being born premature, and that just turned it around completely. It was also hoped that condition would prevent chronic lung disease, but it did not.
It didn't. And surfactant, that's what the baby can produce on their own? That's right. So
if you're born at term, or you and I, we're constantly producing these phospholipids and protein mix, which keep our alveoli open every time we breathe out. Otherwise, when you breathe out, they collapse. Since the early 90s, we've been able to give that as an exogenous, the exogenous surfactant as a therapy, which is delivered directly to the lung through a tube, so basically through an endotracheal tube. So that was a big breakthrough. The other one I had mentioned already was the inhaled nitric oxide. Since that time, there's not been one breakthrough that I can say has changed everything. I'd say if there's one thing from a research point of view that I've been aware of, is the artificial placenta. And there's some really, really amazing work going on in Philadelphia, a group there looking at artificially supporting the fetus. In this case, it's lambs. There's also a group in Toronto that are doing in piglets. And really, if there are many reasons why a baby is born early, and many times it's unavoidable. Sometimes it's because it's for the mother's health that the baby has to be delivered early. For example, preeclampsia or something like that. And if one were able to then essentially put the baby into this artificial womb, if you like, placenta, so that they can continue to grow and avoid all the noxious stimuli that occur when they're born, such as being on a mechanical ventilator, giving oxygen, being exposed to infection and all sorts of things. That would be a breakthrough. It might put me out of business clinically, but that's okay. I can live with that.
Yes.
Obviously, we're talking about something way off in the distance, but I don't think it's science fiction anymore. 10 years ago, I thought it was science fiction, but I don't think so. I think it probably will happen one day.
Yeah.
So if there's a big breakthrough, and I'm not just talking about for lung disease, but all of the complications of prematurity, it would be the artificial placenta. I think that's very exciting.
And the artificial placenta would. How do you think that this? What would you think would be the methods in terms of it being integrated? Do you think it would be coming from an animal, or would it, maybe come from a bioprinting route? Can you think of maybe anything?
Yes. It's essentially. We have the tools to support life, such as extracorporeal membrane oxygenation and so on, which are used during heart surgery and so on. So it's essentially a machine like that.
Oh, okay.
That's sort of miniaturized. At least
goes inside.
Well, yeah. Essentially, yeah. It's the way it seems to be working right now is that essentially the fetus is put in, just like in the womb, in a bag filled with liquid, through which nutrients are given, and their circulation through their umbilicus, just like it is with the placenta, is hooked up to this extracorporeal membrane oxygenator, so that they can continue with gas exchange. I think what we don't know, there's a lot of things we don't know about what the placenta does other than provide nutrients and gas exchange that may lead to some issues, growth factors, other things that it can produce, and so on.
Yes. So studying the basic science still of the placenta is something that needs to be.
Oh yes, very much so. Yeah.
So just before we get going today, I just wanted to ask you about the Advanced Microscopy and Stereology facility at CHEO at the Research Institute. And I think you're leading that. So could you tell us a little bit about that facility and what's being done there?
It's in fact one of the reasons that I was attracted to come to Ottawa was the ability to set up this new facility. And those of us that study the lung mostly rely on histological-based methods to look at the structure of the lung. And that has a lot of limitations that you're trying to ascertain 3D information from a 2D image. But there are ways to overcome the bias that can be introduced into looking at the lung from a 2D point of view. And that whole discipline, which goes back a fair way, back to the 70s, is called stereology. And essentially it's using a very specific way of sampling the lung and determining using geometric probes various bits of information about the lung, surface area, volume, number, and using mathematical formulas to say this is the data I have from a 1/100th of the lung that I've sampled, but it is applicable to the whole lung. And I think one of the reasons why maybe things have been a bit slow or not translated well, let's say there have been many treatments that have worked in animals, but that have not worked in humans. And one of the examples I told you earlier was inhaled nitric oxide. I think part of the problem is that the readouts that were being used to determine this is either having an effect on the lung or not were flawed. And stereology is the best method that we have. It's the gold standard method. But very few groups are using it. I'm actually the only, my lab is the only one in Canada that's currently using stereology for study of the lung. It is used a lot for the brain. And there's only 1 or 2 labs in the United States, a few in Australia, and most of the others are in Europe. But this is essentially Ottawa has the only stereology facility in Canada that's dedicated to the lung. So that essentially is a game changer for us in terms of the quality of the information that we can gather from our models and the effects of our therapies. It also has major implications for the kind of journals we can publish in, for example.
Right.
When you have serological data, which really sets you apart,
Yes,
you can
it's stronger.
the data is that much stronger and that much more nuanced and complex.
Mm-hmm.
So I'm very happy. We've been underway for about a year and a half now,
Oh, wow.
and just starting to get to the point where we're publishing our first data from the use of these serological methods. So I'm very excited about that.
Okay, great. Well, thank you very much for talking to us today on BEaTS Research Radio. And we'll catch all of our listeners next week. And thank you for listening to us today.
Thank you very much.
BEaTS Radio, scientists interviewing scientists. Canada is a worldwide leader in science and innovation. However, our communities need to be more connected to current scientific research in order to drive the future of scientific innovation. So what steps can we take to more actively engage and connect our community with scientists and vice versa? Innovation and discovery are at the core of the current efforts of our government, but science sometimes gets slightly complicated to understand. At BEaTS Radio, we will tackle this by having young scientists and early career researchers interviewing scientists and innovators. By dissecting science in simple terms, this will allow our community to better understand the importance of science for our country.